Good, 30 seconds. Hope everybody had a good weekend. I think Mohammed is attending the HeartMate 3 training at 6:30. Give it about 30 more seconds. All right, why don't we just get going then? Okay, so this is a tracing from the ICU. I was just looking up at the wall at the monitors and bank and saw this. And question I'm asking is, what do you think happened here? So why don't we ask Christina? What do you think's going on here, Christina?
Good morning, Dr. Pass.
Good morning.
So looking at this telemetry strip, it looks like this patient is being paced. And then where the arrows are pointing, it looks like there's a premature atrial contraction. And so that's why the pacing spike doesn't pick up.
Well, that would be a reason there's not pacing, but I think, and I completely appreciate that it's very difficult to tell on a computer screen, but for the sake of this conversation, let's assume that all of these beats are exactly at a rate of 115. There is no change in the rate. Every beat is exactly equidistant to the next. So what would be another explanation, do you think? So yes, I agree. If they were PACs, the pacemaker would stop pacing if the sensing was appropriate. It would sense the PAC and not pace. But in this particular case, all the atrial depolarizations are precisely at the exact same time. Any other thoughts on that?
Could it be that the pacemaker is set at, that this patient's heart rate is 115, that the pacemaker is set, say, around that 115 as well. And so, you know, the pacemaker is not capturing every single beat since the patient's intrinsic heart rate is higher than what the pacemaker is set at.
Well, again, if the pacemaker is set at 115, then it should be pacing every beat at 115, unless the patient had a heart rate that was precisely the same rate as 115. So yes, you're right. It could be that there is sinus rhythm that just randomly happens to be at exactly 115. But any other explanation? So that's certainly a feasible explanation, which is that the pacemaker is programmed at a rate very similar to the patient's intrinsic sinus rate. Although in general, we would usually be pacing at a rate faster than the intrinsic rate. Obviously, this is in the ICU, so presumably this is a post-op patient. This is actually from quite some time ago, a couple of years ago, actually. And I see the SAT is 78. Nobody is running, so I'm assuming it's some kind of cyanotic congenital heart problem. So what else could explain this? So I agree with you. If there were PACs, that would be an intrinsic event that the device should sense properly and not pace. If the patient happened to have sinus rhythm at a rate very, very, very similar, if not exactly the same as the paced programmed lower rate limit, yes, it would intermittently not pace if it sensed the beats at 115. Any other explanations? I'll give you full credit for all of that, but I'm looking for one more. Let's ask the expert in the ICU, Dr. Capon, if she has any thoughts on why this might look this way.
So at first when I was looking, it looked honestly like a sinus rhythm to me. But what gave me pause was the central venous tracing, where you see kind of a blip correlating with the actual pacing spike at some points. So my only other thought was, is it inappropriately pacing?
In other words, inappropriately pacing where? On the paced beats?
Correct. Or like not on the pace beats, I guess just prior to them.
You mean on the ones where the arrows are pointing?
Yeah.
I see. All right. So I sometimes this conference devolves into what is Rob asking you to guess. So I'm sorry if that is the case here. What I really wanted to demonstrate here is that this is an example of this modality on the pacemaker, on the monitor in the ICU that's in many ICUs, which is a so-called pacemaker modality. And so what this modality does is it augments high frequency signals, as are typical in pacemakers, and it exaggerates the pacing spike, right? If you were to do, this patient is paced. And so if you were to do an electrocardiogram, right, we've discussed how we don't ever see pacing spikes, right, this large on ECGs, unless a patient has a unipolar pacemaker. And in the present era, it's unusual that we have patients with unipolar pacing, right? Usually when we look at a 12 lead, the pacing spike is actually fairly small. It can often be seen, but it is not larger than the P wave or almost the same size as the QRS. So these are augmented pacing spikes from the that the monitor is sensing a pacing spike, and it has been programmed to augment it. And the purpose of this is to make it easier for the bedside staff to see the rhythm and understand what's going on. But what you see here are 3 beats where we don't see that pacing spike augmentation. And this to me highlights one of the many reasons that I don't care for this particular monitor approach of it augmenting this pacemaker modality. Because what happens is if it doesn't sense it properly, it doesn't augment it. And as a result, it can make it confusing. When you look at this strip, you assume that there are beats that are not being paced. And you might assume that the patient's sinus rate is competing with the pacemaker. But in fact, in this particular case, as I recall, we went to the bedside, we dropped the pacemaker temporarily, and the underlying rate was like 87. So this is just an example of an artifact in the opposite, where the device is not augmenting on all of the beats because it doesn't see all the beats well enough to augment it. And so I would make the argument that this is in fact confusing because it causes us to come up with concepts of why this is the case, such as Christina appropriately did. But in fact, this is just a monitoring artifact. And it's one of the reasons that I don't care for this particular monitoring approach in the ICU. And I've discussed this with Scott Iden and previous to him, Giorgio Fori, many, many, many times. And despite my protestations, they continue to use this approach. And I find that it's very confusing. The other thing is, sometimes people think the presence of a spike is equal to the presence of capture, which of course it is not. And I would always caution you when you're pacing anybody. If you see pacing spikes, that's great. But what you really need to see is that there is either a P wave or a QRS immediately following each pacing spike. And I have well remember a case where a patient was arresting, and they put transcutaneous pads on the patient because of bradycardia and the absence of wires. And when they were pacing the patient, because because transcutaneous pacing creates a very, very large artifact, everybody in the room thought that the patient was being paced. They were being paced, but they were not capturing. And when I walked in, I had been called to this arrest, and I got up there about 2 or 3 minutes into the code, and everybody was standing there not doing compressions because they were misled to believe that the presence of the large spike on the electrocardiogram was equal to the presence of capture, which it is not. This was not at this hospital. So the point I'm trying to make is you should be very careful to always confirm that there's a P or a QRS after every spike, and you should question when you see this type of a finding, whether this is a real observation or whether this is a pacemaker modality problem. Any questions about that? I think, Ivana, for you, you're going to run into this many, many times in your career. So, and I'm sure you will, over the course of your career, collect a whole series of these types of little mistakes that the computer makes in making, in augmenting high frequency signals. Okay, we'll move on. Okay, so this is atrial extrastimulus testing at 500, 270. Meaning we're pacing the drivetrain for 8 beats at a cycle length of 500, which is a rate of 120, right? 60,000 divided by 500. And then we put in an extra stim in the atrium at 270. And the arrow is pointing here and asking, what happened here? And so I am going to punt this up to Dr. Kalis, our resident burgeoning imager, and force her to look into the world of electrophysiology.
All right. Good morning, Dr. Pass. Okay, just give me a second to kind of look at this.
This will wake you up in the morning.
Yeah.
I will tell you, this patient has a history of SVT.
Okay. So are we pacing? We're pacing in the
Atrium.
In the atrium.
All right, hence the word
And
atrial.
so I think here it looks like I'm honestly not sure, like, because initially it looks like, I was going to say it looks like he was a little pre-excited, but it looks like the QRS morphology looks the same on those last 2 beats as well.
Mm-hmm. And I mean, I think if you look at just at the surface, right, this does not appear to be pre-excited. There seems to be at least a little bit of an isoelectric period between the P wave and the QRS, right?
Mm-hmm.
So we're putting in the extra stim at 270.
Mm-hmm.
What are these beats? What is this here? What are all of these? These A's or V's or hisses?
Oh, so I guess are we?
So here's the extra stem. Here's the
In the
S2.
A.
It says down here S2. So this is the
Yeah.
pacing spike. And then these are what? Atria or ventricles? We're pacing in
I mean, I don't see them in the atrial lead, so I'm gonna say, well, I would think that those are still in the atria.
right, because we're pacing in the atrium, right? So we're capturing the atrium. And then what is this complex?
So then are we going into like an AFib or an flutter at
No, I
this
mean,
point?
over here, right, we see that here's a sinus beat and here's a sinus beat.
Mm-hmm.
There really is just one extra beat, essentially, after so we go A, HV, right?
Mm-hmm.
Okay. And then if we look at this V, right, this is AHV before the extra step. And we look
Okay.
at these V's and compare it to these V's. We notice, right, that all these A's are hugging the V, which weren't here before, right? Right. This is the, look at this beat. This is the ventricular electrogram in the coronary sinus.
Mm-hmm.
Electrogram in the coronary sinus. This part looks the same as this, but then we see all these A's, right?
Yeah. Oh, so is this a retrograde?
Right. So this is so basically what we're seeing is AHV and then a very rapid A again, but we're not
Okay.
pacing, right? We only pace. This is cycle length 500, one premature beat at 270. We have
Mm-hmm.
AHV, and then we have immediately an A right afterwards,
Mm-hmm.
an H and a V, right? And even if you look at the 12 at the electrocardiogram above, right, we see that this R to R is very short, right, compared to,
Mm-hmm.
right? This is the point I'm trying to make here is that this is a tachycardia beat. So we've given one extra stim, and then we've stimulated one extra beat, one tachycardia beat, and then we go back into sinus rhythm after that.
Okay, got it.
And so then the question is, can we make any comments or diagnoses regarding what this tachycardia beat is? And so the can you infer anything based on the interval between the QRS and the retrograde P wave or the next P wave?
Yeah, so it's so short.
Mhm.
We're not like measuring it, but since it's so short, it makes me
I'll
think.
tell you what it is. It's 10 milliseconds.
Okay. Yeah, so that makes me think it's an AVNRT.
Right, right. So exactly. So again, I remind everyone that in AVRT, or otherwise referred to as orthodromic reentrant tachycardia, going down the AV node and up an accessory pathway, the R to P interval or the ventriculoatrial timing is generally greater than 70 milliseconds. And that's simply because it physiologically takes approximately 70 milliseconds to go down the AV node and to go back up a pathway and depolarize the atrium. Whereas in AVNRT, remember that the reentry is above the level of the His-Purkinje system. And so the atrium can theoretically be depolarizing even at the same time or even before the ventricle in the setting of AVNRT, because it really is just a matter of how fast does it take to go from the AV node to the atrium versus how fast does it take to go from the AV node to the ventricle. And in this case, the VA time is very short. Okay. In fact, in the His, the A is unfortunately small in this. So we don't really know where the A is in the His, except it's probably smushed in here. Maybe this is the A on the tail end of the V in the His. But the bottom line is we see that as we go more lateral, the A's get later and later, suggesting that there is reentry close to the crux of the heart where the His catheter is sitting. Also, we notice that the A in the high RA, which is typically in the right atrial appendage and is lateral, is later. It's depolarizing later than wherever the A is here in the His. So this is a single beat of a short RP interval tachycardia. And I would also say, and the other thing that we notice is the A to H interval is fairly long, but we don't really know if there's been a jump based on just this single tracing. So this would be suggestive of, as you said, Maya, of somebody having AV nodal reentrant tachycardia. And sometimes in cases, this is all we get. We are always trying to induce, right? Another possibility is that this could just be, conduction down the AV node and then just a PAC that occurred at the same time. Because remember, we're putting this premature stimulus in quite early. It's cycling 270, right? That's a rate over 200 beats per minute. So if I put a PAC into any of us, we might have a PAC, a reentrant beat just because it's not uncommon. And so we don't really know for sure if this is an example of atrial reentry, a single beat of, shall we say, atrial flutter, or if this is AVNRT. That's one of the reasons. So although it is very highly suggestive of being AVNRT because the R to P interval is less than 70 milliseconds, in fact, it's may even be 0 in this case, it is not inconceivable that this could also be just a premature atrial contraction that randomly is occurring near the His-Purkinje system And that's why it's earliest there. So that's one of the reasons why it's useful to get sustained tachycardia in order to make a better diagnosis. But there are times where we have patients with documented SVT who this is all we get when we're in the cath lab. And this is one of the reasons why Leo Lieberman, who's one of my former fellows, came up with this little witty comment here. He said, "No strips, no service." And the reason he said that was because if you're in this circumstance in the cath lab and you're getting a single beat of tachycardia, you wouldn't normally know what to do, right? Because if you don't know for sure that a person has SVT, in other words, if you just go to the lab because someone has a very strong history of it, but no documentation, we don't really know. The likelihood that this is a sign of AVNRT is strong, but it's not perfect. And so one would be averse to doing, shall we say, a slow pathway modification for AVNRT in somebody who you don't have documented SVT, and the only, quote, tachycardia you could induce is a single beat. However, if you have documented SVT, you would feel a little bit more comfortable making the diagnosis of AVNRT, particularly if you don't have evidence for pathway, an extranodal pathway. So I think it's actually a good statement to suggest that if you don't have strips, you don't have service, you don't really want to go to the cath lab without knowing someone has something, because otherwise, so in this circumstance, what one could do is do a empiric slow pathway on the assumption that this is a sort of evidence that there is underlying AV nodal reentry. This is one of the disadvantages of doing EP studies in children under general anesthesia. In the adult world, this type of procedure for the ablation of SVT is very commonly done with light sedation. And the rationale is that sometimes if you use anesthesia, you can, so profoundly affect adrenergic tone that you make it almost impossible to induce something like AVNRT. And probably one of the most common arrhythmias that are hard to induce under anesthesia would be AVNRT. And so this is something that we always struggle with in pediatric electrophysiology, is induction of this particular arrhythmia. Now, sometimes we're lucky. Most times we can figure out how to get it going, whether it's with isoprel or pacing maneuvers. But in this circumstance, I think this was the most that we were able to induce in this particular patient. And this is the same patient. And what we have here is very similar to what we have here. So in this example, we put a premature atrial contraction in, and we get a conduction down the AV node. So A, H, his, HV, back to A, HV. In the next example, we go AHV, but you notice that we don't have any beat afterwards. But we do have atrial depolarization that is superimposed on the V. And so what this is an example of is, and you see here there's an A in the high RA. What this is what we would call an echo beat. So when you have reentry back up the AV node, presumably up the fast pathway, and then again down the slow pathway, and you conduct to the QRS, to the next ventricle, this is called a tachycardia beat. And that's in contradistinction to this, where we go down the AV node, we do re-enter in the AV node, and we have the next A, but notice it does not conduct to the next QRS. And so this would be referred to in common parlance as a so-called echo beat, meaning that you do see reentry still, so there is still some fast pathway reentry, but there is no further reentry. The question that often comes up at the end of an ablation is if you see this, should you keep going? In other words, there's still some slow pathway, enough slow pathway that you can re-enter up the fast pathway. So does this mean that you could have SVT? The answer is yes, there is a possibility that you could still have SVT. But studies have shown that if you can easily induce SVT before an AVNRT ablation, and then all you get at the end is this, meaning that there's still some evidence of slow pathway, but no inducible tachycardia, albeit echo beats, meaning you get reentry up, but no conduction back down. That probably means that you have altered the slow pathway adequately, that you cannot sustain tachycardia, and probably this is a reasonable endpoint for an ablation for AVNRT. It's quite clear that if you don't see echoes, that's better, right? Because that means you really have knocked out the slow pathway, which is disallowing this reentry. But most experts feel that if you set as a goal during an AVNRT ablation to completely eradicate or get rid of slow pathway, so that you never even see an echo beat, that probably you will start injuring people's AV nodes by being too aggressive. So sometimes we do an AVNRT ablation and we never see an echo again, and that makes us feel pretty confident that we got it and that it's not going to come back. But we will also accept this outcome of an echo beat where there is reentry within the AV node, but it does not then conduct down to cause tachycardia beat. That is considered a reasonable endpoint also. And I'm not sure there's any evidence that that is a less good outcome or a less good is associated with a lower rate of or higher rate of recurrence than when there's none at all. Although one would think probably that's true. So generally speaking, we don't get more aggressive in trying to get rid of these echoes if we cannot induce tachycardia. Now, if I saw this after I did an AVNRT ablation, I would certainly give the patient isopro. I would certainly aggressively pace the atrium and the ventricle, trying my best to re-induce tachycardia, because obviously if the patient's going to have SVT again, we want it to be on the table while we still have catheters in so that we can do something about it. We don't like it when people have SVT in the recovery room. There's pretty much nothing that makes, other than heart block, that makes an electrophysiologist more unhappy. But the presence of an echo in the absence of inducible tachycardia is considered an acceptable outcome for people with AVNRT who've been ablated. Are there any questions about that? I guess not. All right, I think with that, I'm going to stop for this morning. I want to remind you, I had sent out an email last night that we're going to be having a